listen. So one of the optical principles, though we talk a lot about mini monovision, okay. So if you see one eye individually when you do the mini monovision, the eye where you have targeted say minus 0.5 or minus 0.75 actually does quite bad with the visual acuity if you see subjectively as well as objectively, okay. So I think from the optical point of view it is best to target emetropia in both the eyes. I am talking about the contrast and clarity of image point of view. So if you have both eyes emetropia, patient might need near ad, but the vision will be quite crisp. If we do mini monovision, I agree that patient is better off because he doesn't have to, wear the specs for near things. But if depending on the demand of the patient, if patient really wants very crisp near vision, again in those patients also, we may have to give finally some near addition. That's what my experience is with the patients who are demanding about the near vision task. Of course, for all other routine purposes, I think, as Madam rightly said, that patient may not require any glasses. Uh, Nitin.
Yeah, what Madam is saying, there are a lot of published literature on that. In my experience, Triumph Physial lens is a hybrid multifocal and EDOF hybrid, and it is classified as type 4 lens. I routinely combine Triumph in one eye and Physial trifocal in other, and gives excellent near intermediate distance vision. So, and I do it routinely. So what Madam is saying is absolutely right. Even there are a lot of published papers on one eye BVT, other eye panoptics.
Thank you. So we'll move on to the next panel discussion, which are case-based. So I think we would also like you all to join in the discussion if you have any points or any suggestions to do. Just before we start with the panel discussion, certain basics, you can start the presentation. Certain basics about after using the EDOF, I think one of the most common problems, in fact, about the unsatisfied patients is the residual refractive error which is there. So, we have to think whether the autorefractometer readings, whether they change as compared to what we see in monofocals, are they reliable, and any tips for subjective refraction. So, I just want to share these three patients. You can see the uncorrected vision of all these three patients is 6/6, and with a very good intermediate as well as fairly good near vision. So the first patient is a EDOF, second is a trifocal, and third patient is again another EDOF. But if you see the autorefractometer readings, all three are showing different readings. So first, we agree that it's near emetropia on autoref as well. But if you see the third patient, patient is 6/6 for the distance, but autorefractometer is showing minus 1.5 and minus 0.75 cylinder. So that is one of the most problems when we start any new IOL in your practice, and we definitely as ophthalmologists we rely on autorefractometer readings when the patient comes back to you for the post-operative checkup. If patient is 6/6, okay, unaided, then we are not worried, whatever the autoref reading is. But if patient has say 6/9 or 6/9 parts, and now you want to do the refraction of the patient, and now generally because we are so used to now the autoref, we start with the autoref findings, right? But that is something which is problematic. So I want to ask general question to you. I will give you a scenario. So there is a patient who comes back to me. Patient has say 6/9 vision, okay? And you do a subjective refraction, the good old style subjective refraction. And now the patient is reading 6/6 with plus say 0.75 cylinder at say 90 degrees. And patient also reads 6/6 by minus 0.75 cylinder at 180. Okay? You got the scenario? So patient reads 6/6 with either plus 0.75 cylinder at 90 or minus 1.75 cylinder at 180. So which is the refraction that you want to give to the patient? Any of you can answer. Yes. Yeah, so with, okay, you mean to say, the problem with EDOF with duochrome test is there are multiple elements, focusing. So patient may be seeing with duochrome also, both are equal with plus 0.75 as well as minus 0.75, because he is seeing through different, region of the lens. Yes, anyone? Nitin?
it's a tough.
Tough question. Okay.
Yeah. So minus. Yeah.
Okay. So I will just elaborate because the answer is exactly opposite. We have to give plus 0.75. The reason is that when you give minus, okay, you are reducing the range of vision for the patient, right? So patient, when he is accepting plus 0.75 as well as minus 0.75, when we give plus 0.75, he uses the distance element in the lens for looking at the distance, correct? When you give minus 0.75, he is using either intermediate or near zone for distance correction, right? So if you give plus 0.75, patient will enjoy the full range which the IOL is providing. Suppose as he has used say, Lucidis and plus 3 addition is there, he will use, he will have with plus 0.75, he will have plus 3 addition inside the IOL which he is using. But if you give minus 0.75, that near addition is going to reduce and patient may require presbyopic glasses. So you may have to give near addition. Okay, so that is the most common mistake. So think of whenever you are using EDOF or even trifocal, think of that patient as a phakic 20-year-old patient. Okay, so when you have a 20-year-old patient, you do fogging. So you give maximum plus which the patient can accept, okay, or minimum minus, whatever, because we want to use, have the full range of accommodation in use. Okay, so good, that was a trick question, I think it was. Next, another thing, this is one of my patient post-operatively, and I think we never emphasize on the mesopic or scotopic pupil size because most of the, our patients do fairly well with the pupil sizes. But this was an interesting patient post-operatively, and he complained that my distance vision is not clear. And I dilated the patient and checked, okay. With dilatation, he was fine, but whenever he was undilated, he was having 6.6 with minus 2. The moment I dilate, he was 6.6 with minus 0.5. Okay, so why this was happening? Anyone? Yes. So, as ma'am rightly and I had shown in the graphic also, when patients post-operatively have very small pupil, and we do get occasionally these kind of patients when you do more and more these patients. So in these cases, what happens, like I explained in my first talk that I divide the lenses in a different manner. So when we are using a center near type of EDOF, which is Lucidis, where the central element is mainly used for near or intermediate vision, when you have very small pupil, remember the most of the light is being used for near. So when you have that, then patient will require myopic correction for distance when the pupil is not dilated. The moment we dilate, the peripheral elements come into picture, and now because the zone is larger, patient can now see much better without any glasses. Okay, so I think the pupil size is really important about the using even EDOFs. The third thing I would like to emphasize on the angle alpha, which Amit already emphasized on. In monofocals, this angle alpha doesn't matter at all because irrespective of where the light rays are going or where the center of the optic, you have more often a spherical or aspheric optic, it is not going to change the quality of vision. But whenever you have EDOF with these kind of elements, okay, the central elements or the rings, even the VVT, which has a central distance, it has a ring around it. If you have a decentered IOL, patient is not going to be happy because then the visual axis falls on one of these refractive elements and patient is going to see more of this dysphotopsia. So remember that even with EDOFs, you are going to have few patients which are unhappy. So you might, listen to few of us saying that all my patients are good and they are doing perfectly fine. Yes, few patients will still have dysphotopsia and longer neuroadaptation, which is required. So remember, EDOF doesn't mean that you will have 0 patient complaints. Yes, the patient's complaints are reduced significantly as compared to the trifocal. Now we come to the interesting point where we all are going to decide for these patients which type of, so we have 3 choices: monofocal, EDOF and trifocal. So I will be of course starting with the panelists, but any of you differ from them, we'll go ahead and ask you which one you will choose. So we start with the case 1, 60-year-old lady, very typical Indian patient, both eyes are having cataract. Now if you see these 5 categories which I have created in the cases, this is very important. for the thought processes when you are deciding about the IELTS, okay? So I will just elaborate on the things which I have mentioned. The first, I have mentioned fellow eye. So when we see a patient with cataract, we also have to see whether what the other eye is doing, whether it has cataract, it has error, so we'll go on seeing more cases. The second thing is about biometry, where I'm focusing more on the astigmatism part. Occupation, because that's where, you know, the working distance is decided. Hobbies, because that's where you are going to decide what is the most amount of time patient is spending on, and ocular problem. So, Sean, I will start with you. You have the case in front. So, which one will you choose for this patient?
Yeah, actually such type of cases we got always. So if financially sound, then I will go for multifocal or trifocal. Otherwise, if financial not sound, I will directly go for monofocal.
So, no EDOF in this case. This
No
is
EDOF,
a good
sir,
case
because
for
she's
trifocal.
a lady. She don't need reading and all.
Okay, Nitin, I think you agree.
Yeah, but
Is
the
that
only
right?
thing is her in hobbies, there is minimal reading, you know. She's just doing housework and TV. So I won't mind doing a EDOF because it will give her a good contrast and she
Okay,
will be,
so you are thinking of dim lit house or something like that?
yeah. So
Okay,
I mean,
maybe.
and she doesn't read much, so she's doing housework. For
Yes.
that, intermediate is good enough correction.
Okay.
And she's watching TV. And
Yes. Nidhi, anything else? Okay. So I will also go for trifocal in this patient. Second is 65-year-old lady, fellow eye normal, patient is emmetropic in the other eye, minimal astigmatism, again housewife. So most of the things are same except that the fellow eye is emmetropic. Sean, patient is very, very wealthy.
Yes, I will go for trifocal again. You know, even EDOF will work because she's quite young. She can.
She is also a local politician.
Yeah, then go for EDOF.
EDOF.
So that but both are the choices. If she's ready
So
to
if
pay.
politician, then EDOF or trifocal?
If politician, then EDOF.
Okay, good.
the challenge I see here is other eye is emmetropia.
Emmetropia.
So neuroadaptation is going to be an issue if you do trifocal in one eye. I would prefer to do a EDOF or a monofocal in the other.
Nidhi, you would like to counsel this patient more on few things?
Trifocal could work in these cases. Even if the vision is 6/6, we can counsel if there is early cataract for the other eye.
Yeah. And you have to tell the patient he doesn't have to do all the time. Okay? Otherwise, these are bad patients. Next, again, similar thing, 60-year-old man, other eye has early cataract, +1, 6/9. Estimate is minimal. His occupation is farmer. Minimal reading, driving, very occasionally drives at night. No ocular problem. So, Sean, you get a lot of these patients from farms.
Choice is EDOF only, but I don't know which farmer is going to pay that much. But EDOF is the choice, and another thing is that minimal astigmatism is there that can be taken care of.
Yeah, astigmatism.
Yeah.
So, Nitin,
I would talk to the patient, counsel, give him all the three options because
Yes,
he's
perfect.
good for.
I think these farm workers, they want to be free of glasses. In fact, more of these people who are working in agricultural field, and +1 here in the other eye is an advantage because patient has poor distance as well as near vision. I think I will go for a trifocal straight away. The next case is 65-year-old, other eye has cataract 6/12. He has 0.75 diopter astigmatism, just 0.75 against the rule astigmatism. Teacher by profession, reading, also drives at night. Lot of things. Nitin, you can answer this. Can you just sit little in front so voice is audible?
See, even 0.75 I will not like to ignore. I mean, I put every 0.75 in a toric calculator. If it is toric, I do a toric.
Yes.
There are limited options of EDOF torics. I don't mind doing EDOF toric for this patient because he loves driving at night.
Yes, perfect. I think the take-home message is, even if there is little amount of against the rule astigmatism, you put it on Barrett calculator and use toric EDOFs whenever possible. Don't rely on anything else. Remember, as I was mentioning in my first talk, emmetropia gives you crisp vision. Okay, anything less than emmetropia, there will be loss of contrast sensitivity there. We'll move on to the next. 50-year-old lady, this time a HR manager, other eye has PSC, 0.75 with the rule astigmatism, has dry eyes, rest of the things are normal. Reading and mobile use is the most common hobby. HR managers are, in any organization are the most hated people, but they are the people who want to be in, control of most of the things. So, Nitin, any particular this thing?
She has a dry eye, so fixing
She has dry
is
eye.
very important.
Yes.
Then her task is going to be distance, intermediate, near all at the same time. As I have mentioned, I'd like to combine a hybrid with a trifocal.
Okay.
She is the right candidate for that.
So trifocal for you, I think bilateral cataract, and with the rule is 0.75. You would like to change the incision anyway?
No, I don't change my incision.
So you'll still take a,
I'll put it in the calculator, and if
Okay.
it is showing toric, I'll go for a toric.
okay.
Arcuate.
Yeah. Yeah. So I think as Chitra madam said, every patient you put on Barrett Tori calculator and say as the calculator says. Yes,
We
Nitin.
did a study, madam, on femto-LRIs, and it works really well with the rule. If it is against the rule, then femto-LRIs don't work as well. So as you have rightly pointed out, since it's with the rule, femto-LRIs are going to work really well.
Yeah. So now the same patient, but the other eye is emetrope. We get this patient quite frequent nowadays, 40s, 50s. One eye is emetrope, one eye has cataract. Now the same thing, she has a lot of hobbies, reading, trekking, so outdoor activities are there, software engineer by profession. So what will be your choice in this particular case?
Could you come again, sir?
So software engineer, other eye is uncorrected 6 by 6, no cataract. Okay, and software, reading, trekking, mobile use, kind of outgoing person, lot of activities involved, and of course dry eye which comes quite, often with software engineers. So which IOL you will
Software
use?
engineers are very demanding. They are like, they want everything perfect. However, it's one eye, so I am little concerned about neuroadaptation. I have done it in the past and burned my fingers. So I will go for EDOF now because I have done it and patient, although was 6, 6 and 6 was not happy because other eye was
Emetrope, yes,
yeah,
yes.
So I mean, so I avoid such situations.
Can you give mic to madam? Yeah. So that is one more option. What I would
She's a
personally
driver
do,
also, ma'am. She can drive the car. But
so seen as a glasses. I think that's the right perspective there.
I have found this problem with Americans, Indian Americans who come here for surgery. You do a trifocal, they go back and they complain that driving is a problem.
Yeah, that is
because
true.
this thing happened.
I might, think in terms of a EDOF with higher near addition in this particular case, like say Lucidis or, which has a refractive element. Yes.
Yeah.
Yes. Minivel and Lucidis, they have higher additions.
Proxa and Minivel.
Yeah. So I will just skip through. Now this is another common, 18-year-old traumatic cataract. We'll say that zonules are all right, everything is okay. Pupil is, traumatic midrias is there. Patients is, now these are the young patients, they will spend, their parents are ready to spend anything to get the perfect vision for their, son or daughter. So what will be your choice? Nidhi?
Tori Kidov.
Tori Kidov. Patient unilateral cataract, other is 6 by 6. Nitin. So it's a similar thing which as compared to, but here the patient is very young. That's the difference. And we see a lot of these patients who are ready to spend. So for them, they say that you choose the best for my child.
Again, traumatic midriasis is another
Yeah,
issue.
correct. So when you look at, the picture, you have to look for traumatic midriasis, and many times it is missed. If you have a traumatic midriasis, no matter which aisle you put, patient will have a lot of issues, contrast is lost. So if you are planning a EDOF, do it with a pupilloplasty. Don't do it without, managing the pupil. So that's the take-home message from here. I have also few patients with home steady pupil. Sometimes we miss these findings in the OPD. So it's very important that we see the pupil size when you are doing biometry. So if you have biometry which picks up the sizes, I think that will be great. This is another common scenario, 35-year-old Fuchs heterochromic iridocyclite, other eye 6/6 because they are typically unilateral. Again, a young, outgoing guy in marketing, reading, mobile, night driving. So there are few KPs as we expect and few floaters. Again, these are the patients we commonly get. They are, in profession, they don't have problem with money, and so he wants the best. Nitin?
I will still counsel him for a monofocal. I don't want to do any fancy lens because his uveit is young guy. We don't know what's coming. So monofocal, preferably heparin coated.
Yes. Yes. So one option is enhanced, like I said in my talk, that if you have addition less than 1 diopter in the IOL, usually MTF function is still good, and patient will not feel the loss of contrast. Remember, anything in the vitreous, patient loses contrast. Okay, it's not just about the corneal fuchs. With fuchs iridocyclite, you also have floaters, lot of floaters, and these patients have significantly reduced contrast. So I generally avoid any lens which reduces the contrast. Now, this is another thing. Both has significant cataract, housewife, mobile use, housework, but has moderate glaucoma. So, Nitin, this is also your field.
As I presented in the study, 6% cases had glaucoma. So mild to moderate glaucomas, we can choose EDOF.
EDOF.
But advanced glaucomas, only monofocals.
Okay. Sure. So my, I always feel with glaucoma or any retinal disease, for example, age-related macular degeneration, there is always loss of contrast. So myself, I will always choose either a enhanced monofocal to keep the contrast intact, or if at all patient is quite, want little bit of glass-free vision, I will go for a low near-ad EDOF, like lentis comfort or something like that, because invariably as patient is going to progress, well, there will be some loss of, fields, and patient, I have seen 60-year-old, so she is going to, live for another 20 years. So we just have one case I will just discuss before we finish. So this is a retired, I think which I already discussed with early RMD. I think this is one of my common observations. We miss this early RMD patients. So when we see this kind of changes, drusen or pigmentary changes on the retina, the patients already have lost a lot of contrast sensitivity, which we don't pick up. We feel it's because of cataract, but till the visual changes of ARMD come, already the contrast has been lost. So these are the patients who always have problems with neuroadaptation, and they'll still keep on complaining that the vision is not clear post-operatively. So if you find any ARMD patient, just avoid any of these contrast-reducing lenses. This is common for all. A general surgeon who still operates, so he's a general surgeon, he wants to get rid of, because these are the patients who come very early, cataract is just early, 6/6 part, the main problem is the contrast is lost. So, Nitin, and he's a pre-diabetic. So,
I don't mind doing that hybrid trifocal and a trifocal because he's demanding work and a need for a continuous near vision. I think this combination of a hybrid with a trifocal is really working well for me.
Anything about 50-year-old who is pre-diabetic?
Pre-diabetic,
So
that also has to
see,
consider.
A 50-year-old pre-diabetic doesn't mean much because he may control it well. He
Control
is
it
conscious, he's a surgeon. So I don't think the chances of him going for a proliferative retinopathy are low.
Do you look at the specialty of the surgeon, like he's a gynecologist, he's a laparoscopic surgeon, he's a ophthalmologist, like he uses microscope or does a general surgery?
If you see a laparoscopic surgeon, he's seeing here screen,
Yes.
he's looking intermediate at the instrument, so I think he needs everything. I think a surgeon needs full range of vision.
Yes.
And occasional driving, which obviously, how much are we going to drive at night? I think trifocals and the newer hybrid trifocals are going to do really well in these cases.
Yes. So I think we have to discuss all these points, because many times the general surgeon, they use these retractors, which sometimes, gives lot of glares back. So these are the patients you have to, emphasize that there will be some issues with this, and whether he wants to focus on the profession where he can still use glasses and have crisper vision, or he wants to, have something in between. Lawyer, okay, other eye cataract, lot of reading, doesn't drive at night at all. Yes, Sean?
EDOF for me.
EDOF. Now
Trifocal, but this time
he is a lawyer.
I will prefer
He is a
EDOF.
lawyer who specializes
With good
in
counseling.
he specializes in medico-legal issues.
Yeah, that's why with good counseling, writing, last line I will write, you may need little bit correction. That has
Okay.
to be there.
So I had a similar patient, I counseled him for anything, and he said, doctor, if you have medical legal cases, I am, specialized in that. So I said, we'll go for EDOF. Okay. So another 50-year-old man, high myopia, okay, very high myopia, best corrected vision is 6/9. Marketing is his job. He wants to get rid of glasses. Little bit of nuclear sclerosis already set in, so you want to do, correction. Yes? Nitin?
If there is no retinal pathology like
No retinal, he's-
papilloma or something, then trifocals work really well
Okay.
because they are used to good near
Shown?
vision.
Same, sir.
Yes, Chitra madam. Yeah.
Yes, madam.
Yes. One more thing about with these high myopes, never go for, if you want to give a very good near, vision, never go for any EDOFs which have low ads. Okay? Because optically, if you see their lens power is also less. For example, they may get 10 diopter IL power or something like that. And optically, their effective near addition is always less, okay, as far as the physics goes. So patient who has got 30 diopter, suppose IOL with VVT, will have effective higher near addition as compared to a 10 diopter IL, same IL, VVT, okay. So that's in physics. So that's why many high myopes, which are, we put lower ad, these EDOFs, they don't like the near vision at all. So always for myopes where the IL power is less, go for the higher addition, even these trifocals. I find trifocal results are much better in these high myopes. And they are more accepting for a lot of, glares and halos as well, because the happiness of getting rid of these very high myopic glasses is very much. Yes.
Madam, if the post-refractive patient has a EKR like a Burj Khalif, would you want to also think of a trifocal? Because if EKR value is a tall EKR thing, then probably if it is a short building with a spread out, maybe you can avoid trifocal. But if it is a single tall peak, maybe we can consider it, isn't it?
So I think basically, Nitin, what happens is that the physics will tell the same thing. That there is already operated LASIK, you are further reducing the contrast.
Yeah.
Okay. The difference is because of the patient's, biology. Some patients are more accepting, they have higher retinal sensitivity and they will do fairly well. But some patients, they may not be very happy. So I think whenever doubt, go for a lens which has better contrast sensitivity. That's the, I think. Okay, so thank you so much. I think we are at the end of the session. Thank you so much for attending, and thank you all my co-panelists.